So welcome to chapter 5, the skeletal system. This one's an interesting chapter. It's a little bit long. It's longer than the last chapter. So let's go ahead and get started. Right, so the skeletal system is divided into two different sections or two subdivisions. The axial skeleton and the appendicular skeleton. We'll talk about those a little bit later. Also, the parts of the skeletal system that we're going to talk about specifically are the bones, which is the skeleton itself, joints, cartilages, and of course ligaments. We'll talk about all those to at least some degree. The function of bones, the purpose of bones, and what they do is they actually support our body. It provides a framework for our body. It also protects some soft and delicate organs, such as the brain behind the skull and the spinal cord behind the vertebrae. The rib cage also protects a lot of vital organs, such as the lungs, which are very delicate, and the heart. It provides a very important service to keeping our internal organs safe, and also keeps them in the right spot. A place for muscles to attach to allow movement. Also, they are some mineral stores, storing calcium and phosphorus, even some fat in the internal parts of the marrow cavities. And also inside of bones is where red blood cell formation occurs, also known as hematopoiesis. That's a tough word. I always struggle with that one. Don't ask me to spell it. There's no way that I could. It has more than 2 vowels in it, so I'm exempt from having to spell it. The adult skeleton has 206 bones. 2 basic types of bone tissue that we're going to talk about. The first one being compact bone. It's dense, smooth, and considered homogeneous, meaning it's all kind of in one piece. It looks like kind of what you would expect bone to look like. The other type is spongy bone. It kind of has these needle-like pieces of bone, and it has many openings, and it's a little bit more like a spider web of sorts than compact bone. So it has a very distinctly different look than the compact bone does. So when we take a closer look at those, we can see that spongy bone. It's that porous looking bone. That's the spongy bone, and it serves a very important purpose. And then we can see there's some compact bone there too, and it's that smooth looking bone that we're accustomed to seeing. Typically, the spongy bone, we don't see it. It is hidden behind compact bone most of the time, so it's not something that we see. But it's valuable that we have that particular type of bone, because if our bodies were all made up of dense or that thicker bone, it would be, or we would weigh a lot more. Our skeletons would weigh a lot more. So that spongy bone allows us to have less weight, while still maintaining a high degree of strength. So the way that we classify bones is based upon their shape. Bones are either long, short, flat, or irregular. And that's basically how we classify them. And when we take a look at a few bones, we kind of get the idea. Long bones, it shouldn't come as no surprise. We would expect to see this would be a long bone. So these are long bones. Here, those are very common long bones. On the other hand, we have some flat bones. This one right here, like in our sternum, is a flat bone. And then we have some really kind of irregular ones, some like the vertebrae in our backbone, and then some short bones, like the talus down here in the foot. So that's how bones are classified, is according to basically their shape. Obviously, long bones are typically longer than they are wide. It sounds kind of weird in saying that, but they're longer than they are wide. That's what makes them a long bone. They have a shaft with heads situated at both ends, and those are basically attachment points. They're mostly made up of that compact bone, they're dense bone. All of the bones in the limbs except for the wrist and the ankle and the kneecap are considered long bones. So the bones in your wrist, the bones in your upper arm, and the bones in your legs all the way down are considered long bones. So Examples of that, of course, is the femur and the humerus, the femur being the thigh bone of your leg and the humerus being the upper part of your arm. Short bones, usually they're kind of a cube shaped, and they mainly are made up of spongy bone, include bones of the wrist and the ankle, and even the sesamoid bones are a type of short bone that's formed within the tendons, and the patella is an example of that. When you think of short bones, think of carpals and tarsals. The bones of the hands and the bones of the feet are the best example of short bones. And there's a picture of it there. Flat bones are thin, flattened, and usually curved. So when we think of flat bones, usually they do have a curve to them. Two thin layers of compact bone surrounded by a layer of spongy bone. So we'll see this in the ribs. It's kind of surprising that the ribs are considered flat. We would think that they're round. They're actually flat. They're not round like we see them depicted in skeletons hanging on front porches around Halloween. They're flat bones. The sternum is a flat bone. The skull is also a flat bone. And most of those bones are actually derived from membranes, especially the ones in the skull. But you see the skull here. When we see a cross section of that skull, we can see the, if I can get my pen to come up, there it goes. We can see the compact bone right along here on either end. It's kind of sandwiching the spongy bone here in the middle. And what that does is it gives a lot of strength, allows there to be a lot of strength and protection without adding to a whole bunch of weight. If the entire skull was made up of compact bone, the head would weigh a lot more. As it is right now, the head weighs 8 or 9 pounds, and it might add either a few ounces or a pound or something like that to the weight of the head, which can be rather dramatic. And there's an example of a flat bone. Regular bones, obviously they have an irregular shape, and they don't fit into these other categories. So they had to create a category specifically for them. Hip bone is an example of that. And of course, vertebrae, they're just odd-shaped bones. But they have such a specialized purpose that's why they're odd-shaped. And you can see the hip bones in here as well. Come on. Hip bones right here as well. You see how oddly shaped those are. Well, remember, when we're talking about bone shapes, it's just like everything else in the body. Form follows function. So depending on its function is going to determine its shape. So vertebrae have their shape based upon the purpose that they serve. Not all vertebrae are the same shape, though, because they're in different locations throughout the spinal column, and therefore they have different requirements of what they need to do. So now that we know the different classifications of bones and the different shapes of bones, let's look at long bones in particular. When we look at the anatomy of a long bone, one thing that they have is they have a diaphysis, or the shaft, the center part of the bone, which makes up most of the bone's length. Usually that shaft is primarily made up of compact bone. We also have something that's called a periosteum. It's the outside covering of the diaphysis. It's that fibrous connective tissue membrane that's on the outside of the bone. Almost all of our bones, especially our long bones, have this membrane that surrounds the bone. A lot of things happen with that membrane. That membrane is very valuable. It's very, very important, and it serves a lot of purposes. It's anchoring points for blood vessels and tendons and ligaments and all that kind of stuff. So the periosteum, the covering on the outside of the bone, is very, very vital. So we see a cross-section of that long bone here, and we're talking about this section, the middle section of the bone. We're talking about the diaphysis here. That's the center section of that bone. We're not talking about the ends yet. We're not talking about the ephysis on the ends, the proximal and distal ephysis. We're talking about the diaphysis. And you can see how this is made up of dense bone. It is solid, thick, dense bone. The purpose in this, why this is such dense bone, is because it can handle weight and stresses a lot better being denser. So this bone is actually a bone that's designed to carry weight. And so it needs to have some denseness to it in the middle, but yet on the ends it's not quite as critical on the ends because there's a couple of things that it needs to do that's important. We'll talk about that here in just a minute. And this talks about, this kind of breaks that bone down, the diaphysis of the bone into the, mainly what we're looking at here is the periosteum, this membrane that surrounds that bone. And you can kind of see some of the work that it does, but it is very well attached to this bone. So it's not just a membrane that's kind of covering the outside of it. It is a membrane that is actually attached to the bone, and you can see all the little blood vessels in this thing. It actually provides some anchoring points for blood vessels to come through and nourish the bone itself. And like I talked about earlier, in some places it's attachment points for tendons and ligaments to attach to the bone. And it does that through the periosteum, or by means of the periosteum, that membrane on the outside. The ephesus, these are on the ends of the bone. Kind of alluded to those just in that last picture. We'll get back to looking at them a little closer. But they're on the ends of the bone. These are mainly made up of spongy bone enclosed by a thin layer of that compact bone. And then we usually have some articular cartilage that covers the external surfaces of the ephesus, usually made of a hyaline cartilage. What this articular cartilage does is it decreases frictions at the joint surfaces. It also helps with a little bit of cushioning. We can see the articular cartilage there on the outside of that. It's not a great picture. But the reason why the ephesus is made up of this spongy bone, in part it's a weight issue. It reduces the weight of that bone overall. The other thing that it does is that because of the nature of this meshy looking network that we see here, all of this in here, this actually acts as a little bit of a shock absorber too. So we've got this articular cartilage out here that kind of, it provides movement, a slippery surface kind of movement, also some cushiony effects here. This bone inside has some cushiony effects. So as we're running, jogging, walking, doing those types of things that are creating different forces upon the bones, this is acting as kind of a shock absorber of sorts, much like what's in your car, absorbing those bumps and things like that to where that they're less jarring and less likely to cause damage to the thicker bone, to that heavier bone out here on the outside. So, or in the shaft, the shaft part of it. So there's also an epithelial plate. We've probably heard about these before. This starts out as a hyaline cartilage. While we're young and as we grow older, it goes away, but it causes the lengthwise growth of a long bone. And once that plate has closed off, we usually see the remnant of that plate, and we call that the epithelial plate. And we see that in adult bones. And we'll take a lot closer look at that right here. Oh gosh, I'm sorry, that's not what I wanted to do. Okay, there we go. We can see several things at the epithelial, at the ephesus. And this, of course, this one's proximal because it's closest to the body, and this one down here is distal because it's further away. Very similar in many ways. But we can see all the spongy bone inside of this up here that's going to act as a shock absorber. It's going to protect the compact bone down here by absorbing a lot of the shocks that go on. And now we see this epithelial line. This line right here was once cartilage. And as the bone grew, what happened was as new cartilage cells were created up in here and they started to go further away, mainly in this direction, they started to get further away from the cartilage. Those cells in there get surrounded by the bony matrix and they actually turn into bone. So as this in here is creating more cartilage cells and more cartilage cells, and they're getting out further and further away, it's causing this bone to grow longer this way, and even some from right to left, so it gets wider and longer. But as these cells, these cartilage cells that are created in the epithelial plate get further away from where they are, their origin, they get surrounded by the bony matrix and they actually become osteocytes. They become bone cells once they're completely surrounded. Eventually, this epithelial line will start to get thinner and thinner and thinner as the growth of the bone matrix begins to take over and grows faster, and eventually that will completely take over all of this section right here until all of that cartilage is actually surrounded and becomes bone, and it can no longer divide and create more cartilage cells, and when that happens, bone growth stops. And usually that happens, 16, 17, 18, 19 years old. It kind of depends on whether you're male or female. It happens at different rates. But that's basically what happens when, in the early stages of bone growth, as we're growing, as a child grows and they get taller and taller and taller, it is those cartilage cells that are being pushed out of the epithelial plate in various areas throughout your body, being pushed out through the epithelial plate. They get surrounded by the bony matrix. They become bone cells, and forever are bone cells, and they can no longer create. Eventually, the bone growth will overtake that cartilage region right now, that epithelial cartilage, and it will no longer be able to produce more cartilage, and we stop growing. We no longer grow any taller. So if you're a very short person, as my middle daughter is, she's a very short person. Apparently hers overgrew much more quickly. But that's that, and that's where we see that epithelial line. The problem is we hear it talked about a lot of times. Oh, well, you got to break near the growth plate. Well, if we break that, if at a young age we have a fracture, we suffer from a fracture in that near this or right on that growth plate, what'll happen is the healing process may actually cause that growth plate to close up faster than what it was programmed to do, and you wind up with one leg shorter than the other or one arm shorter than the other because the injury damaged that growth plate and caused it to close off, caused it to bone in, so to speak, sooner than what it was supposed to. That's the concern of a fracture too close to the growth plate. Inside of the long bone, we have the marrow cavity, and it's that cavity inside of there. It contains some yellow marrow that's usually fat in adults, some red marrow that's red blood cell production in infants. In adults, red bone marrow is situated in the cavities of the spongy bone of the Ephesus and of some long bone. So in that center cavity, mostly in adults, it's mostly fat. In the diaphysis of that, in the shaft of that long bone. And the marrow in the ends of that, the red bone marrow in adults, is where the red blood cell production actually occurs. So in the center part of this shaft, in here, in infants and children, is where red blood cell production is taking place. But as adults, when we reach adulthood, that begins to happen in the ends down here because the bone marrow has migrated to the ends. And what we see in here is mainly just fat storage. It's not putting anything to waste. Actually, the fat storage in the middle acts as another means of a buffer or a shock absorber of sorts. It's also a good place to store things, so it's where fats are stored. Surface features of bones, there are various different markings and things on bones. Bones are not just absolutely smooth. They're bumpy, they're rigid, they have a strange look and feel to them. So they're not always completely smooth. So expect those to be, there'll be bumps and grooves and fissures and holes and all kinds of things on the surface of a bone. These are all different attachment sites for muscles or passages for nerves and blood vessels to go through. Those categories for those bone markings, there is a way to categorize them. If it's a projection or a process, usually the name of that begins with a T. If it's a depression or a cavity, the name of it will oftentimes begin with an F. So if you're trying to determine, if you see a test question, which I don't think there'll be a lot of test questions about that, I'm just not a big fan of you guys focusing a whole bunch of time to the different names of different bone markings, surface bone markings. But if you happen to see something and it's a projection or a process and you're trying to figure out which one it is, it probably begins with the letter T. If it's a depression or a cavity, it's usually going to begin with an F. I'm just one right off the top of my head is there's some of them that are called fissures that are a depression. It's like a groove in the bone that's where maybe a nerve or a blood vessel or something runs along the line, along the surface of that bone, and it runs in a fissure to kind of protect it, and that's why it starts with an F, because it's a fissure. Okay. If we look at bone a little bit more closely, especially compact bone, we take a close look at that. Osteocytes are bone cells, and they're situated within cavities known as lacunae. Lacunae, however you want to pronounce that. These lacunae are arranged in concentric rings called lamellae. And then the lamellae are basically rings situated around a central Haversian canal. So I know it's a whole lot of new words and a whole lot of new things, but it's really not quite as complicated as it may sound. So when we take a look at this, let me get my pen back up here. Come on. Here it goes. Okay, you can see these little yellow kind of dot looking things in here, this little yellow, whatever those are, you know. What are those things? Well, those are osteocytes. Those are bone cells. That's what those are. And those are in a lacunae. And you can see the lamellae, which is the rings. It's pointing to these rings here, the lamellae. All right, so, and within those are these lacunae, okay? That's all that's talking about. And then now we've got this Haversian canal, is this canal right here in the middle, and the whole thing, when we take the laminae, lacunae, the osteocyte, and the blood vessels in the middle all make up the Haversian system. So basically, we've got this canal down the middle that has a artery and a vein and usually a nerve. And then we have the in concentric layers of osteocytes or bone cells surrounding that. And this right down here is a little better depiction of a lamellae. And then we can see the osteocytes down here. And then here's the central canal right here in the middle. So that's basically the network of how bone is laid out. Now, remember, we're looking at this on a microscopic level, so obviously when you look at a cross-section of bone, it may not be quite so obvious of what you're seeing, because these blood vessels that are in here are going to be pretty small blood vessels. You might see some of those features, but you can see this one up here, this where they've cross-sectioned this, and we can see this canal right here running down the length of this. Notice that there are places along the way that interconnect with, that goes across ways and goes across those particular canals, so that all of this interconnects with each other. That's just a way that the whole system can interconnect, intercommunicate, and do all kinds of things. Remember that bones are living organisms, they're alive. What makes bones hard and dense and all that kind of stuff is the nutrients, or the things that are stored within it, the calcium and all that stuff that's stored within the matrix of that bone, within this whitish colored part of the bone. That's what gives bone its density and its firmness and its hardness. But we have all of these osteocytes in here that are alive and living along with other cells. Osteocytes are not the only thing going on in there. So it's vital that they have a good blood supply. So nutrients can be brought in, waste products can go away. We also have some nerve endings in here that are sensory nerve endings. that let us know when something's wrong so that we can sense pain in our bone. That's why a broken bone hurts, is because there are nerve endings inside of the bones that sense pain. So that is the Haverson system. Kind of have an idea of how that works and what that looks like. So this Haverson system is open in the center of basically an osteon, runs lengthwise through the bone, carries blood vessels and nerves, just like we said. An osteon, remember we talked about osteocytes back here, the individual little yellow things in there. These little things, remember, these are osteocytes. These are bone cells in there, right? And when we look at that whole Haverson system, that whole Haverson system that it's talking about there, this system right here is often referred to as an osteon. So osteocytes, osteon, Haverson system, there's a lot of new terminology there that can be confusing, but what we're looking at here, for instance, if we take this right here, everything inside of here, inside of this is an osteon or a Haverson system, okay? So that's what it's talking about with an osteon and the Haverson system. And it's just how we can break that particular bone down into individual units. And each individual unit's going to carry, it's going to contain several osteocytes, several bone cells. So another little cross section, we zoomed into it a whole lot more. We're looking at that Haverson system, or a fourth of that Haverson system, and we can see a lot better the bone cells in here. We can even see their little nucleus. And you can even see these little cross canals that interconnect, so that these bone cells actually do have a way of communicating with each other to a degree. Getting its nutrients here keeps all of this, the whole system healthy. Storage of calciums and different nutrients in this bony matrix here is what gives it its strength and rigidity. It's also a great place the body can use those stores for later in emergencies when it's necessary. Okay, there's a true microscopic view of that an osteon, and we can see the canal and the central rings and all that kind of stuff in that. So that's an osteon. We kind of talked about this as those caniculi, or those little canals that radiate from the central canal into the lacunae. They're part of that transport system that interconnect the bones. I talked about it here. You can see that it looks like cracks in that, and that's what they're referring to as the caniculi. And then there's the Volkmann's canal that runs perpendicular to the central canal, and it carries the blood vessels. If we back up here, it was these canals that are going in between the big bundles of blood vessels. It's these canals right here, is the canals that it's talking about when it talks about the Volkmann's. Is that right? Yeah, Volkmann's canal. So those are the ones that it's talking about. Okay, onward and upward. There are some organic components or organic parts of the matrix that make the bone a little bit more flexible. There's some calcium salts that are deposited in that matrix that make the bone hard. So there are things that make that bone flexible. We want to think of bones as being just absolutely rigidly hard and very brittle. Bones are actually pretty strong and pretty resilient, but bones obviously can be broken. They're very unique in the way that they're made. There's some solid things that make them very hard and dense, but yet there's some other things that cause them to be a little bit flexible. So bones have both of those properties. One of the unique thing about bones is they do this thing called ossification. And that has to do with bone formation and bone growth and also bone repair. And ossification is the process of bone formation. And of course, it occurs in the hyaline cartilage that we talked about in those epithelial plates. Remember, we talked about that just a few slides back. And And of course, when it's long bone, it's going to involve two major phases. But this ossification is what happens when the hyaline cartilage is actually calcified into becoming bone. So we see that here with these images, that, we start off over here, and in an embryonic state, the bone is nearly all hyaline cartilage. In a fetus, we see that there is some actual bone tissue there, but there's still a lot of hyaline cartilage. But in a child, notice that we have very little hyaline cartilage left. Remember, this down here and this up here is articulate cartilage, and it's not hyaline, it's not the same. But these two right here make up that epithelial plate. Remember what's interesting about the epithelial plate, as more cartilage is produced, more cartilage cells is produced from the epithelial plate, and they move out further from the center of where the growth is happening, and that they become calcified, or they become surrounded by the bony matrix and actually turn into osteocytes. Okay. All right, there's two major phases of ossification that happens in long bones. We have these osteoblasts, which are bone-forming cells, and they cover the hyaline cartilage model. And then we have enclosed cartilage, which is digested away, opening up the medullary cavity. I know it sounds really complicated, but just bear with me for a minute, and we'll get through this. Hopefully you'll understand it. When we're born, most of that cartilage is converted to bone, except for those two regions, the articular cartilages and the epithelial plates. The articular cartilages stay. Eventually the epithelial plates will go away. New cartilage is formed continuously on the external face of these two cartilages. Old cartilage is broken down and replaced by a bony matrix. So as more of this cartilage grows, more of it is actually replaced by a bony matrix. It's broken down and replaced. This causes a growth in the length and the width of a particular bone. It grows in diameter as well. This is controlled by hormones such as the growth hormone. The epithelial plates are converted to bone during adolescence, and the growth in the bone ends. So once the body reaches a certain point, it's amazing how our bodies do these things, but at a certain point, a switch is flipped, and all of a sudden, growth hormones are shut off. The epithelial plates are triggered to turn off. They're actually overgrown with bony matrix and fully enclosed, and no longer capable of creating more cartilage cells. Because of that, cartilage cells are no more. There's no way to produce new bone growth as far as length. There are ways that they've kind of tricked the body into doing this. They've done some things with little people where they've tried to lengthen their bones. It's a very arduous, painful process, but basically they break their bone, put them in these metal contraptions like on their legs, break their bones, put them in these metal contractions on their legs, and slowly over the course of weeks or months lengthen the contraption that they've got on their legs. They turn some screws on it and slowly lengthen it. Every week they give it, like a quarter of a turn or half of a turn. And as the bone is trying to grow back together, they're moving the bone, keeping the bone far enough apart where it keeps trying to grow back together. And eventually they stop that, let the bone go ahead and heal, and that particular person is taller. We also see that with someone that's actually had an epithelial plate damaged, and one leg or arm or whatever is shorter than the other. That's the procedure that they can use to correct that. It sounds pretty morbid, but apparently there's several people with those conditions that go through that endure that just for some normalcy in their life. Of course, bones continue to lengthen until growth is programmed to stop. And then bones are constantly remodeled throughout our life in response to two factors: blood calcium levels, If we have too much blood calcium, we'll store calcium in the bones. If there's not enough calcium in the bloodstream, we will pull calcium from bone into the bloodstream. Calcium is a vital element in the body for the proper function of not just nerves, but muscles and various different parts, various different things within the body. So it is critical that the body maintains the proper calcium levels. Too much calcium messes things up, not enough calcium messes things up. So calcium, excess calcium is stored in the bones, not because there's nothing else to do with calcium. Calcium can actually be eliminated from the body, but because it's so vital, the body opts to hang on to a lot of the calcium for emergencies. And calcium also makes up the hard, rigid part of the matrix of bone as well. So it strengthens bones. The second thing that actually affects remodeling of bones is gravity and muscles. Remember I talked early on about form follows function, but if you're one of those types of people that you go to the gym and you work out a lot and you build up big strong muscles, well, people with big muscles have big skeletons because those muscles put the bones under a lot of stress. If you took my puny little bones and put the muscles of a very young Arnold Schwarzenegger, and I use him as the example because usually everybody knows who he is, but a young Arnold Schwarzenegger's muscles on my puny little skeleton, if I tried to do something like lift something or run or do something like that, it would probably snap my bones like a twig. So that's why it's important that bones are able to respond to those stresses. So just like muscles, when we go in a gym and we stress the muscles, it stresses the bone and causes the bones to grow. So bigger musculature on the outside of the body means a bigger skeleton on the inside of the body in response to that. It's just, if we stress it, it's going to grow. Okay? Parathyroid hormone plays a role in this. It's released when the calcium levels are too low. And what that does, if the blood calcium levels are too low, the parathyroid hormone is released. It activates cells called osteoclasts. Remember, osteocytes are bone cells themselves. Osteoclasts are bone destroying cells. Now, they don't go in there and destroy osteocytes, but they go in there and they start breaking down the bony matrix, the matrix of that. And what that's going to do, it's going to release calcium ions into the bloodstream. So parathyroid hormone is released when blood calcium levels are low. It's going to activate the osteoclasts, which are already there. It just turns them on. They'll start destroying, breaking that down. And when the parathyroid hormone goes away, when there's no longer that hormone present, the osteoclasts will go back dormant again. Hypercalcemia is a condition of high blood calcium levels, which will prompt the storage of calcium into bones. And storage of calcium into bones is not by osteoclasts. Remember, osteoclasts break it down. Storage is done by osteoblasts. Oh my, bunch of new words and they all have osteo in them. You have my sympathies. If you're struggling with knowing these, get your book out, make you some flashcards, put osteocyte, osteoblast, osteoclast, osteon, those kinds of things on one side and put the definition on the back side, and just put the doggone things in your pocket and practice them wherever you go for the next week. If you do that, the repetition will get it in your head and you'll have it down pat. So that's a real easy way to help you learn new terminology and new words that there's several of that can be very confusing when you're trying to sort them out. Easy way to do that. Fractures, when we have a break in a bone, we call it a fracture. There's different types of fractures, two types in particular we call it open and closed. A closed fracture usually is a simple fracture, but believe me, I've seen some closed fractures that were anything but simple. Basically, it's closed because it doesn't break the skin. An open fracture, oftentimes we call it a compound fracture, same thing. It's where the skin has been broken and the bone is protruding through it. So that's the two categories of them. The way that we treat fractures, no big mystery here, is we reduce them and immobilize them. So we reduce the fracture, and what that means is we line the bones back up, and then we immobilize it so that bone has a chance to heal. Bones are very, very good about healing. unless there's a really, really serious, severe type of a break, and then there's some things that's going to hamper healing. Oftentimes, a lot of bones are treated with what's called a closed reduction, meaning the bones are manually put back into place by a physician. It's usually an extremely painful procedure, but it's a lot less risky than going to surgery. If you've ever had a physician try to manually reduce a fracture, you'll know exactly what I'm talking about. I've had it done before. Unfortunately, it didn't work. I got to have all the nice, wonderful pain from it, and then go to surgery anyway. So, and then there's the open reduction, is where they go in, surgically fix that. Not always is it that they go in. Sometimes they can surgically place it with pins. They can manipulate it into place and then pin it through the skin. And it's kind of like the pneumatic air nail guns that they use for building a house. It's small versions of those that they're, putting nails into bones to hold them into place, to pin them into place until they have an opportunity to heal. A lot of times the pins stay in place. Sometimes they do remove those pins, but a lot of times they stay there. When a bone is broken, oftentimes we get that blood-filled swelling or a hematoma. There's some a fibrocartilage callus forms. Basically, it's a cartilage matrix, and it kind of helps, the collagen fibers will kind of help splint that into place a little bit. And then eventually a bony callus begins to replace the fibrocartilage. And then osteoblasts and osteoclasts migrate in and do bone remodeling, trying to fix it. So when we look at a broken bone, a bone that has been broken on x-ray, a lot of times we can see that it's been broken because there's like a little knot right in the middle of it. Well, what's happened is the bone in the body has recognized, hey, look, that thing was weak right there and it broke. So when we fix it, we're going to actually add a little extra to it so that it doesn't break there again, or we're going to add a little extra to it so that we can make sure it stays solid until it's good and healed. And a lot of times that a little extra isn't reabsorbed. So that's why even old fractures, very old fractures, you can still see on an x-ray. If they've healed properly, it's tough to see them the longer that it's been healed. But if it didn't heal properly, it's very, very obvious on an x-ray that it was a broken bone that didn't heal properly. So here we see that this is just a visual representation of what we've seen in the last slide. But in one, we can see the hematoma, that blood that forms in there because we had some broken vessels. And then as time goes on, we see some cartilage that forms in there, some cartilage growth. That cartilage growth will eventually begin to be replaced by a bony matrix, spongy, and then a solid bony matrix. And then over there on the right is where the remodeling has occurred. What you'll notice too is notice that there's more blood vessels in that area after it's healed. It's a little bulged on the sides from where all that repair has taken place. Eventually, most of that will be reabsorbed, and the evidence of a fracture will become less and less, but there'll probably always be some small evidence of that there was a fracture there, that there was some damage. Common types of fractures, we have commuted, where the bone breaks into many fragments, kind of a shattered bone. Compression is where the bone is crushed, where the two ends are pushed together. Depressed is a broken bone portion is pressed inward. Of course, impacted, the ends are forced into each other. Spiral is a kind of that twisting. And then, of course, green stick is the bone breaks incomplete, where it's still partially attached. Kind of like when you take a twig and you break it, but it's still attached, but it's broken. That's why it's called a green stick. It's like trying to break a green stick. So we see examples of what those fractures look like here, and a picture of them. We see the commuted and compressed. We see compressed or depressed skull fractures is oftentimes what we see. Spiral and green stick, those kinds of fractures. Okay? All right, so the two divisions of the skeleton. We've talked about the bones and the makeup of bones and the repairing of bones. Now let's talk about the two divisions of the skeleton. The first one we're going to talk about is the axial skeleton. It forms the longitudinal axis of the body, And it's divided into three parts: the skull, the vertebral column, and the bony thorax. And I know you're probably going, what in the world is he talking about? Well, it's really not that tough. You see the kind of blue, green, whatever weird color that is the axial skeleton. We can see that it's made up of, so when we're referring to the axial skeleton, it is made up of these components right here. Okay, that's the axial skeleton. That's it. That's it in a nutshell. Nothing overly complicated about that. Skull, rib cage, the spinal column, all the way down is all part of the axial skeleton. Okay, and we see the backside picture there too. All right, so we look at the skull. Skull was made up of two sets of bones. There's cranium, and what I mean by two sets of bones, there's a lot of bones in the skull. But if we was to divide the skull into two sections, this is how we would do it. The first would be the cranium, and there's several bones that enclosed just the brain. The second section would be the facial bones. The eyes, the jaw, facial muscles, and all those kinds of things are attached to these facial bones. This doesn't mean that these bones can be easily separated, that the cranial bones and the facial bones can be easily separated. They can break apart in kind of a weird way, but it doesn't mean that there's an actual big-time division between the two. They're attached to each other. So, but it's just a way that we can further divide the skull in a way that's easier for us to absorb and understand. The bones in the skull are joined by sutures. Basically, it's because a lot of the skull was from membrane, hyaline membrane, and the way that it grows together. Only the mandible is attached by a freely movable joint. So the mandible is the one bone that is not fused together to the rest of it. So 8 cranial bones protect the brain. Remember, this is the first of the two sections. We've got the frontal, occipital, ethmoid, sphenoid, the parietal bones, the temporal bones, and there's 8 of them. And then there's 14 facial bones. Here's all the facial bones. All of them are paired except for the mandible and the vomer. All of these have pairs. There's more than one, so that's why there's 14 of them. Okay, and here's just a picture of the skull, and we can see that the cranium, I like that word, cranium, is kind of this, like right here. Actually, it's going to go that way. Okay, well, maybe not. Maybe, I think that would be right. That's the cranium. Mainly, it is separating the, it is housing the brain, and then you have all of the facial bones here. All of those facial bones. I like how they put them in different colors so it's easy to distinguish them. See this little hole right there? That's your ear hole, and of course your eye sockets, nasal cavity, all that. Temporal mandibular joint. If you got one of them that click all the time, that's the culprit right there that's making all that clicking noise when you're chewing. Here's a bottom look at it. Remember where it talked about what, according to whether it's a fissure or something like that. Of course, it's not really. See, that's a foramen. It's an F, so because it's a hole. Foramen. Okay. This one right here, though, that's where the brain stem comes out at the base of the skull. And this is actually with the top half of the skull cut off, and we're looking like down inside of the cranial vault, inside of the brain where the brain would set. We're looking out, and this is looking out. This would be down where the spinal cord is, where it comes out down along the spine. That's what we're looking at there. This is from the bottom side of the skull. From if we was looking underneath it, and of course the mandible, the jaw, lower jaw is gone. What I'd like to point out on this is this is pretty good. Mainly we're looking at bone labeling, and I'm not just going to sit here and name off bones. I want to point out some features. Right here is where the brain stem comes out, and you see these two little pads right here. These little pads right here. Those little pads right there is where the axis, or maybe it's the atlas, I can't remember which one the first vertebrae is, but these little pads are the resting points on top of that very first vertebrae of your spine. And that's where they set. They actually have a place that they set on in order to be able to turn and do the things that it's supposed to be able to do. Notice this here. Those are drainages. That's drainage points from the sinus cavities. We can see parts of the sinus, some other sinus cavities here, some openings here, here. Lots of openings, and these are this is ear holes. There's several openings in here, in the skull. This is cheekbone right here. Getting a fight and get your cheekbone broke, that's why it's not a real rigid thing and for most of us. You see this little deal like this, it's called a styloid process, probably has some kind of tendons or ligaments or something attaching to that as an anchor point for us to be able to turn our head and all that. All kinds of different processes and things that are going on in there. Now, I know what you're asking yourself. Is he going to give me a test where I have to label bones? You might have to know the name of some bones, but not these little bitty meticulous bones. It would have to be radius, ulna, femur, tibia, fibula, those types of things. I'm not going to say, hey, you need to point to the vomer. I'm just not going to do that. I'm not going to get that detailed about it. So just because I think it's almost cruel. This picture though right here, there is an assignment. One of the assignments that you need to do is you need to label this. And I know it's going to be super simple to do. This picture's in your book and all of it's labeled, but this is just something that I want you guys to do so that you become familiar with these words and these names of these different things and the bones and that kind of stuff. It's mainly a familiarity exercise, less so much that I want you to memorize everything. And I realize it's not going to be a tough thing to do, but you start to get familiar with the names of things like the zygomatic bone and the ethmoid bone and those types of things. You get familiar with them. Okay? There are some sinuses in there. We didn't see all of those, but they're buried kind of back in there a little bit. But they're hollow portions of the bones. And mainly we see them around the nasal cavity, but that's not all of them. They have, their purpose is not only to lighten the skull, but they also amplify sounds as we speak. That's why whenever we have a cold and our sinuses are stopped up, we start sounding like this, is because those hollow portions inside of our skull are no longer resonating the sounds and the airflow that's moving out as we speak, and it's messing everything up. So we look at these, and if you've got a cold or a sinus infection or something like that, and you ask yourself, well, I understand why my face hurts, but why do I have a headache? Well, because you have these frontal sinus up here that are very well known for causing headaches. Why do my eyes hurt? Well, you got the ethmoid sinus there too, and of course these maxillary sinus, we're pretty familiar with those. Those are all much bigger than most people realize and think. We all know that there's a cavity in here, an air cavity that we're moving air in and out of, and we think of that as our sinus. That's really not. That's the nasal cavity. All of these are sinus cavities. Our nose is a nasal cavity. Our nose is not a sinus, which seems kind of odd, but it's not. See, we look at these sinuses here, and we've even got one over here, the ethmoid over here by our temples. Oftentimes makes us feel like our eyes hurt when we have a sinus infection or whatnot. Crazy little bone called the hyoid bone. It is closely related to the mandible and the temporal bones, but is the only bone that doesn't articulate with another bone. So if you ever ask a test question that says, what is the only bone that doesn't articulate with another bone, always think of the hyoid bone. And it serves as a movable base for the tongue. It also aids in swallowing and speech, but what is the doggone thing? Well, it is the Adam's apple. And we see a picture of it here, the hyoid bone. It's also the bone that pathologists will look at very closely if they suspect somebody was strangled to death, because this bone can be broken during strangulation. Now, it doesn't mean that it is always broken during strangulation, but it is quite often broken in strangulation events. So they'll look at that. All right, the fetal skull, the skull of infants while they're still in utero, is large compared to the infant's total body length. Baby heads are big. If you haven't noticed that, start looking at the little ones that are around you and go, wow, that kid's got a really big head. And the reason why is because the skull doesn't grow that much bigger after we're born. It does a little bit, but not a lot. But in relation to how much growth goes on in the other bones throughout the body, the skull grows very little. It does grow, don't get me wrong. The skulls do get bigger and they do grow, but not as exponentially large as, say, the little, a newborn's little legs and how much they'll grow when they're just a little fella and they become a basketball player that's 7 foot tall. So the skulls do grow, but not as much in compared to the rest of the body. Fetal skull is usually about 1/4 of the body length compared to the adult skull, which is only about 1/8. So you can kind of see how much difference there is there. The fontanelles, the soft spots in a baby's head, are just membranes connecting the cranial bones. What this does is it allows that skull to compress during birth without damaging the brain or breaking the bone. And it also allows the brain to continue growing during later parts of pregnancy and infancy. So the brain can grow absent the bone, relying on bone growth of the skull. Remember, form follows function. Unfortunately, the brain doesn't grow in a way that actually would push the skull out. So the more you learn doesn't necessarily mean your head gets bigger because you're putting more information in there. That's not the way that it works. So infant bones, babies and infants' skull bones are made primarily of membranes, so the brain can grow up to the first 24 months after they're born. And we can see the little fontanelles there, and those are little soft spots that we got to be careful of with the little ones. Until they're about 2 years old, they'll close up pretty well then. These suture lines that we see here will, up until about the age of probably mid-20s, early 30s, there'll be some kind of distinguishment so that we can look at a person's skull and tell their age based upon how complete the growth is between these bones or in these suture lines. So in these suture lines here, we can actually tell age based on how complete those suture lines are and how much we can still see those suture lines. And here's their squishy little heads. It just looks so alien when we look at this. But all this will grow and everything will grow into place like it's supposed to be. New parents sometimes will freak out because their baby's heads are oddly shaped, but rarely is that an issue. Okay. And spinal column provides axial support and extends from the skull to the pelvis. So we have the spinal column actually gives us our ability to stand up, to hold our head up straight, turn our head and all that. 26 single vertebral bones are separated by intervertebral discs, these shock-absorbing discs in between the bones. There's 7 vertebrae in the neck, 12 in the thorax, 5 in the lumbar. Those are all good things to know, so make you some flashcards with those on them. Those are all very, very valuable things to know. There's also 9 vertebrae that fuse together to form 2 composite bones. In the sacrum is formed by the fusion of 5 vertebrae, and the coccyx is anywhere from 3 to 5. It kind of varies, and it may be difficult to distinguish, and that's what we're talking about down here at the very bottom, the tailbone. But 7 cervical, 12 thoracic, 5 lumbar, and then 9 fused, sacral and coccyx that are fused together. I had a really good friend of mine. He was 6'6", or maybe he was 6'7". He actually had 6 lumbar vertebrae. It was a weird deal. He had a lot of back problems too. I think it was associated with that. There are some normal curvatures of the spine. The primary curvatures are in the thoracic and sacral regions. Those are there from birth. It's kind of C-shaped curvature as in newborns. And secondary curvatures are in the lumbar regions that develop after birth, and it kind of gives us the S-shaped curvature in adults. And we can see that here. You can see that kind of the S shape. Those are normal curvatures. We have some abnormal curvatures. If the spine curves to the side, we call that scoliosis. An abnormal curvature forward, like we see in this, like this poor little lady standing here, that's kyphosis. And then a lot of times with our pregnant moms, when that belly gets sticking out there and they're trying to maintain their balance, they're leaning their head and pulling their shoulders back more and more because that belly's sticking out and they're trying to keep their balance. That's what we call a lordosis. So those different shapes, and we typically see those to an extreme, and that's why they have their own classification as being abnormal. All right, we take a closer look at the vertebrae, each of the vertebrae of the spine. Each one of them has a body, a vertebral arch, and then there's a foramen, that's the hole in the middle where the spinal cord goes. Some transverse processes, which are attachment points for muscles and ligaments. There's spinous processes and superior and inferior articular processes where it attaches to other ones. So we can look at all those processes on here. You can go all kinds of crazy trying to memorize these and label them, but I'm not going to test you on them. So don't panic. I just don't want you to focus your studies on something that I'm not going to test you on. But you can see all those different processes on there, the spiny processes. The hole in the middle where the spinal cord goes, passes through there. The very first two vertebrae of our spine called the atlas and the axis, and I always get them backwards. I don't know why, but atlas is the first, axis is the second. We're talking about the cervical vertebrae. So atlas is C1, axis is C2, and then we got 3, 4, 5, 6, and 7. Remember, there's 7 vertebrae in the cervical spine. So, but the very first two, you remember me showing you on that skull, when we were looking at the base of the skull, those two flattened spots, and that's what these are going to match up to and where those are going to set, and that's where the weight of the skull sets. And then, of course, these down here are going to attach to these, where these are going to set on there, and this is where and of course, right here's where the spinal cord passes through. The interesting thing about these two, if there is a fracture and a separation of these at this point, and if it's a significant enough separation of these at this point because of some sort of an injury, it is instant death, because it's going to actually sever the point of the spinal cord before it branches out to the heart, and the heart will stop beating. There won't be any nerve impulse to the heart, no nerve impulse to the lungs, and all that. After C2, that the nerves branch out, the cranial nerves branch out, and it innervates the heart and the lungs. You'll be paralyzed from basically the top of the shoulders down, but you'll still have a heartbeat and be breathing. Now, Superman, Christopher Reeve, broke C2 when he fell off of his horse. He wasn't breathing, but his heart stayed beating on its own. Your heart has the ability to beat on its own, absent a nerve impulse, and we'll talk about that in the cardiac chapter. But when he fell off of his horse and it broke C2, he was fortunate because there was somebody right there, and they provided not CPR, but ventilations. They breathed for him, mouth to mouth, that kept him alive until he got to the hospital. And then he wound up in a wheelchair on a ventilator for a number of years before he passed away. Very rough life living like that. And it's just, though you would think you could live for a long time with that kind of paralysis or that kind of injury, really it's not good. Your body will deteriorate, and that's kind of what happened to him. So moving on down, we can see these processes and the way these vertebrae look. The typical look of the cervical vertebrae. Look, they're not real heavy, they're not real thick, they're not real dense. They look pretty delicate and flimsy. Well, that's because they're not supporting a whole lot of weight. As we move on down to thoracic, these start to take on that kind of Jurassic Park look. Start to look like we would expect vertebrae to look. Remember, these are also interacting with ribs, so they've got a costal facet for ribs, so the ribs actually are attaching to these, or at least articulating with these. So these start to look more and more like vertebrae that we would expect to see. We get down to lumbar. The lumbar region is where a lot of weight is carried. So all the weight of our upper body, plus if we're carrying things, lifting things and all that, all of that weight is carried there. And you can see that these are much bigger. And also the hole in the middle of that is getting smaller because as we move down this spinal cord, more and more nerves are branching out. So the spinal cord is getting smaller as there are less and less nerves in the spinal cord. And then along about L2 or L3, I can't remember for sure exactly where it's at, we have the cauda equina, which is where the spinal cord completely leaves the vertebrae and then goes out and branches out and down the legs. Right along in there is where you'll have that the sciatic nerve, like the longest nerve in the body, that sciatic nerve that goes down the leg, that gives people a lot of trouble. And then, of course, we've got these last few vertebrae right here that are all fused together in the back part of the pelvis. They're all fused because they make up the back part of the pelvis. Okay? All right? All right. So that bony thorax of it protects the major organs, or the thorax, I'm sorry. I was trying to figure out where they were going. We're talking about the rib cage. We're talking about the chest, the thorax. It's that protects the major organs, and there's three parts of it: sternum, ribs, and the vertebrae in the back that we've already talked about. We can see that there are 1 to 7 pairs of, there's 7 true ribs, and they're in pairs, sorry. Ribs 1 through 7 are true ribs. False ribs are 8 to 12, and then there's floating ribs as well. Men only have 1 pair of floating ribs. Women have 2, and it's believed that that's to help support the baby during childbearing years. When a mom's pregnant and carrying a baby, it provides more support. So that's the 3 parts. We can see those here. We can see the true ribs up here at the top, the false ribs because they don't come around and attach directly to the sternum. That's why they're called false. And then we've got these floating ribs down here at the bottom. Okay, not really any big mystery to that. Up here in the sternum, right here in the middle, this piece right here in the center, the sternum, this right here. Actually, there's a pretty good sized bone marrow cavity in that. It's one of the places that we actually can use to infuse fluids, medications, and those kinds of things. So it's a painful cavity to use, but it is possible that we can infuse fluids into bone. We have this device, it's called a bone drill, and it's got a needle on it and a bone needle, and we drill into the bone. We hook an IV up to it. We can give fluids and medications. We can do it there, but we typically don't. We usually do it in the top of the top arm bone, the humerus, in the very top up by the shoulder, or right there, kind of the top of the shin. The top inside of the shin is another place that we'll do it. So we can see where this lines up in the cross section. You can see the heart right here in the middle, and we see the rib cage and all that stuff, how that all interplays. The appendicular skeleton is comprised of 126 bones, and it's the limbs, the pelvic girdle, and the pectoral girdle in the shoulders. I'm just going to kind of quickly go through these. I'm not going to spend a lot of time, but it's everything outside of that greenish, bluish colored skeleton. So it's all the outside stuff. The shoulder blade has 2 bones that attach: the scapula and the clavicle. Scapula is your shoulder blade on the back. Scapula is your collarbone. Collarbone, it only takes about 14 pounds of pressure to break a collarbone, so it doesn't take much to break a collarbone. It's the most commonly broken bone in the body, is the clavicle, or the easiest, I guess, maybe not most common. And then, of course, the pectoral girdle is a poorly enforced girdle, but it actually allows for a whole lot of movement in the shoulder. This is if you've ever had torn rotator cuff or that kind of thing, or shoulder problems, the shoulder is poorly enforced, so it's easily damaged. But the great thing about it is it allows for a lot of movement. So it's not a flaw in the design of humans. It is actually a benefit in humans, but it's a testament to the limitations of what humans are capable of doing. We can't always do all of the things that we think we should be able to do, and as a consequence, we wind up damaging our bodies. So here's a view of the clavicles. and there's the shoulder blade on the back. There's the right and left. The humerus is the upper part of the arm. It's the long bone, the very upper part of the arm. And it's the humerus, you know, when you hit your funny bone on your elbow, there's the nerve that runs right down that. It's called the humeral nerve. And that's why it's called the funny bone, humerus, funny bone, humeral, you know, so that's where all that comes from. And of course, the distal end articulates with the bones of the wrist. Not, like I say, I'm not going to get real crazy into these, but this one is a long bone. And you see this deltoid tuberosity. That's actually where the deltoid muscle, the muscle attaches. And you see because of that attachment, has actually pulled the bone out. It stressed the bone and caused it to pull out like that. It's the way that works. And of course, then you see the groove down here. It's pointing to this radial groove. That's actually where artery, vein, and a nerve run down that crease right there, and it's a way that that's protected. Bones of the forearm are the radius and the ulna. The radius actually rotates around the ulna, and it's on the thumb side. So if you're trying to find the radius, it's always on the thumb side because the radius, it radiates around the ulna. The ulna stays straight. So when you're holding your hand out like you're asking your parents for money with your palm up, and then you can take your hand and then turn it down. Notice that the bone that is right behind your thumb in your wrist actually rotates around, but the ulna, the one on the inside, stays in one spot. So that's why it's called a radius, because it radiates around the ulna. Okay? It's held together by that interosseous membrane. If you've ever had tendonitis or tennis elbow, that's where it is. That's the cause of it right there. That inflammation and swelling and pain in that, it has to do with that. They call it tennis elbow because it was associated with tennis players, you know, hitting their backhand and all that stuff, causing damage to that. The hand has carpals in it. The easy way to remember that, you drive a car with your hands, so carpals, car. 8 bones arranged in 2 rows of 4 bones each. The metacarpals are the palm of the hand. So the carpals are in the wrist, metacarpals are the palm, and then the phalanges are the fingers and the thumb. Okay? And we can see those right there. All right? Metacarpals, be careful you don't mix them up with the phalanges. Remember, there's only 3 bones in the phalanges. So if you start at the very tip, you go 1, 2, 3, that's the phalanges. The 4th bone is the metacarpals, and then the rest of the bones are the carpals. Okay? It's usually the best way to do that. Pelvic bones, formed by 2 coaxial bones, and there's parts of 3 pairs of those bones that are fused together. We don't usually look at them as being separate, but the ilium, ischium, and pubis, they form that pelvic girdle that protects everything in that, and it supports the weight of the body. It protects all those organs in there, the reproductive organs, the bladder, and parts of the intestine. We can see that, and we see the big hole in the bottom of this because that's where all these organs set in there, and then, you know, on the sides, on the iliums there, where it's supporting organs and all that type of thing, and distributing the weight of our body down to our legs. It's amazing how our bodies is put together in order to be able to do that. There's a side view of it. That acetabellum right there, that's where the hip joint plugs in, and there's a ligament that attaches right to that. Oftentimes when somebody breaks their hip or dislocates their hip, they tear that ligament, and the ligament there is irreplaceable. So once you've dislocated your hip, you're more susceptible to that because odds are you've tore that ligament that holds it in place. Female pelvis is a little different than the male's, if you didn't know that. A little larger inlet, more circular. All of this is for childbirth. The whole purpose of the way that the female pelvis is designed is for childbirth. It's not so medical examiners can determine whether a skeleton is male or female. Nope, it's all about childbirth. It's form follows function, and the purpose of it is to allow for easier childbirth. And that's why it's shaped the way that it is. You can see the difference in the two. And that's how they determine. All right, so femur is the thigh bone, heaviest, strongest bone in the body. It's as strong as concrete. as the same size, but it doesn't respond well to side impacts, and those kinds of things can still break it. The head of that articulates with that acetabellum that I showed you, and then distally it makes up the knee, or when it attaches to the tibia and fibula down low. So you see the head of it up there at the top, right there where it's pointing to the neck of that. That is where we typically see a hip fracture. It breaks it right here, usually between the greater and lesser trochanters is typically where we see that break. Oftentimes it's here or here is where we'll see the break. And depending on how bad the break is, 90% of the time they will just cut the head of that off and nail a steel rod down inside of here with a new fake head on it. Yeah, that's how they'll fix a broken hip. They'll do the opposite on the other side. Two bones in the lower leg, we call them the shin bone, or the shin bone's usually the tibia, larger and more towards the middle. So if you're trying to figure out which one is the tibia, it's the shin bone, and it's towards the middle. It's the one in the middle. The fibula is thinner, it's smaller, it's more like a stick, and it's on the outside. And it does not form any part of the knee joint. It has more to do with the stability of the ankle, holding the ankle stable in conjunction with the lower leg. The foot, just like we drive a car with our hands, we walk on tar with our feet. So tarsals are the 7 bones of the feet. And then we have metatarsals form the sole of the foot, and phalanges are the bones of the toes. Remember, just like our hands, the first 3 bones starting at the tips of the toes, the first 3 bones are phalanges. The next bone is the metatarsals, and the rest of it is the tarsals. Remember, there's several more different bones to the tarsals in the way that they distribute the weight and what they do, and the calcaneus, the heel bone, all that stuff. Arches of the foot, the bones of the foot are arranged in they're supposed to form 2 arches, 2 longitudinal and 1 transverse. The purpose of these are so that the way that we walk and the way that our foot makes contact with the ground. Eventually, as we get older, the ligaments that are holding all these bones together will start to give way from gravity and weight and all that stuff, and we'll have what's called fallen arches. It will give us problems, make our feet hurt. Of course, I'm not going to spend a ton of time on joints, but they are articulations where two bones meet. They're designed to hold bones together and allow for mobility. There's the immovable joints, so-called synthrosis, slightly movable or amphitherosis, and diathrosis are freely movable. Don't worry about those words. There's 3 different types of joints. There's fibrous, cartilaginous, and synovial. Fibrous are generally immovable. Cartilaginous, they may move or be slightly movable, but not a lot. Synovial joints move freely. Looking at fibrous joints, these fibrous joints are where bones are held together by fibrous tissue. Usually they're immobile and they have sutures between them. The best example of that are the joints of the skull. Okay, so those are just those fibrous connective tissue joints. Okay, we can see some down there at the bottom on the tibia too, but the cartilaginous, they're connected by fibrous cartilages, and those types we can see those like in the rib cage where the rib meets the sternum. Those joints like that where there is some movement there, like when we breathe, but there's not a whole lot of movement. Also see that in the vertebrae and down there in the pelvis as well. Synovial joints where it's freely movable. We see the different types of synovial joints. We have multi-axial, such as the shoulder, uniaxial, such as the elbow, biaxial is the hand. Within those synovial joints, we usually have some flattened fibrous sacs called bursa. They're filled with synovial fluid, and they're not really part of the joint, but they help cushion and help with the movement. And then we have some tendon attachment that attaches in there too. Types of synovial joints are based on shape. Don't worry about trying to memorize all of these types of joints. It's not something that I want you to be overly concerned with, but I just want you to be aware of that there's some names of these. Ball and socket's pretty easy. Shoulder and hip are those. Pivot joints, hinge joints, saddle joints, that's more like the elbow. So a lot of different types of those. Okay, well, I was wrong. Yeah, hinge joint. I was right. Never mind. I was thinking I was wrong. Just kind of feel free to look at those on your own. Those slides are on there. So there are some conditions, inflammatory conditions, that are associated with joints that we need to be familiar with. Remember we talked about that bursa, that fibrous portion that's in there. We can get a condition called bursitis, usually caused by friction. Tendinitis is inflammation of the tendon sheaths. Tendinitis, tennis elbow, those types of things. Arthritis is an inflammatory or a degenerative disease. There's a whole bunch of different types of arthritis. Basically, in a nutshell, it's a progressive damage to those joints. We can see those in a lot of different joints, even the joints in our back, hips, knees. It's not necessarily only associated with a certain type of joint. Sometimes it has to do with genetics. Other times it has to do with what we did as a living. And then sometimes we just don't take good care of ourselves and we cause these types of problems. Osteoarthritis is a common chronic, probably a result of normal aging is what it says. Rheumatoid arthritis is an autoimmune disease where actually the immune system begins to attack the joints. Here's a picture of rheumatoid arthritis and the damage that it causes those joints. It's massive. There's another condition called gouty arthritis caused by deposits of uric acid. This is very treatable. Most of the time it's controlled with diet. It's more common in men. Also, if it's not controlled with diet, it's pretty easily controlled with medication that'll help that. We talked about the fontanelles that allow birth and growth of the cranium. But here's a picture of a little in utero baby in their skeleton, where we can see the dark points of the skeleton. Those are formed bone, and everything else is still cartilage, so it's still growing. So there's a lot going on there. It's a little tougher to make out on the skull side of things, just because there's a brain inside of there that's making it a little bit tougher to see. So fetus, we talked about this too. It's just kind of repeating that. Their bones are formed from hyaline cartilage, and the fontanelles remain till about age 2. At adolescence, those epithelial plates become ossified. Long bone growth ends. So if you are a 25-year-old and you're still hoping to grow taller, I've got news for you. It's not going to happen. It's over. Usually by about the age of 22, 20, 21, 22, all that growth is gone. A lot of times for women, that growth stops around 18 to 20. Men sometimes will go 22, 23 before, but it's dramatically slowed down by that point in time, to the point that they don't really realize that there may be still a little growth going on there. And let's see, we see how the human newborn and adult skulls grow. We see, I don't know why they felt the need to have a picture of the growth rates, and so they put a naked girl up there and showed how she grows, in case we didn't know that. Skeletal changes throughout life. The primary curvatures are present at birth. Secondary curvatures occur as we develop, and then we might have some abnormal curvatures that are oftentimes congenital, associated with some sort of a disease that may begin to show up. Osteoporosis is a thinning of bone. It's a disease. Happens in about half the women over age 65 and about 20% of men over age 70. So it does affect men as well. It makes the bones fragile, and they break much more easily. The vertebral collapses that are associated with this are result in that kyphosis, that kind of hunched back overlook. This is what happens with osteoporosis. It's not anything that can be fixed. But sometimes there's some treatment for it, watching calcium levels and bone density levels and those types of things. But it's kind of like having a predisposition to high cholesterol. It's a difficult thing to care for. There's just not a lot out there. Estrogen helps with that in the females, but we can kind of see that develop over time. Once again, naked women. I don't know what the deal is. And progressively aging naked women. I don't know, make of it what you will. Okay, so that's chapter 5. Try not to let it overwhelm you. It's not as bad as some of the chapters we've already covered, so you should be in good shape. Feel free to email me with questions, and I will see you on chapter 6.